Welcome to our video history session. We are extremely pleased today to have with us one of the pioneers in the field of reproductive endocrinology and contraception, Dr. Daniel Mishell. Dan, thank you very much for agreeing to come and meet with us today and share with us some of your insights into our specialty, obstetrics and gynecology.
Thank you very much, Ralph, and it's a pleasure to be invited and spend this time with you and our audience.
Okay. Let's begin so that people can learn a little bit about you. Where were you born?
I was born in Newark, New Jersey in 1931.
That's a little far away from Southern California, where you did so much of your work. How did you get to Southern California?
Well, my father was a gynecologist, obstetrician gynecologist, and in World War II he enlisted as a general surgeon and was stationed in Iowa and also in Indiana for a while, and then he was transferred to California, which was a faraway place for from those of us on the East Coast. And we lived in California. When he came back after the service, he went overseas and was in the China, Burma, India theater and did surgery there, the flyers who came over the hump, which was a very dangerous mission that they took. And when he returned after the war was over, his practice in New Jersey had dried up, and he remembered fondly of his days in California, so he moved to Los Angeles and opened an office in Beverly Hills practicing obstetrics and gynecology. And I went to high school there and then applied to college at different places and was very pleased to be accepted at Stanford University. So I went there for undergraduate and applied to medical school and was accepted at medical school at Stanford. It was very difficult to get into medical school in those post-war years. This was 1948 when I went to college. But I was accepted. There were only, I think, 60, 65 medical schools in the country. It's very difficult to get in, very competitive. So I was accepted and went to medical school at Stanford. One of the nice things was that you only had to go to 3 years undergraduate. So I entered medical school at the beginning of my senior year in college and went to Stanford Medical School. And then when it came time to take an internship, back in those days, you may recall we had rotating internships and before starting a residency. And I took a rotating internship at Harbor General Hospital, which became Harbor UCLA. And then after that, I applied for an internal medicine residency because I thought that was especially I wished to spend my life doing. And I was accepted as a first-year medical resident in New York at the Bellevue Hospital in the Cornell Division. But after 1 year there, we had what was called the doctor's draft in those days, so you could postpone your service time when you took a residency. And I was thinking I really didn't like internal medicine that much, but I was drafted in the Air Force, spent 2 years in Texas as chief of medicine at a small Air Force hospital. And after that, I decided I wanted to be an obstetrician gynecologist like my father and applied for a residency. We didn't have a match in those days and was accepted by the UCLA team and took my residency at Harbor UCLA. It was a 4-year residency after a year of internship. And I did that. And during part of our residency, we were able to have research time. And most of the residents did chart reviews, non-binding research. But the chief at Harbor UCLA at the time was Luigi Mastroianni. And Dr. Mastroianni convinced me to go to work with Carl Gemzell in Sweden, in Uppsala, Sweden. And Professor Gemzell was the individual who first utilized human pituitary gonadotropins to induce ovulation in anovulatory women. And he extracted the pituitary glands from cadavers and separated the FSH and LH and used this to induce pregnancy. I thought I was going over there to learn that. Because that was really a major advance in those days, because we didn't have clomiphene citrate. And ovulation was one of the biggest problems in infertility. There was no good way to treat it. A lot of people used corticosteroids, even irradiation of the brain. And I thought Professor Gemzell was going to teach me how to do that, but he was very secretive about it. And he had patients come from all over the world to utilize this therapy to induce ovulation and cure their infertility. But he placed me in his laboratory down in the basement of the women's clinic in Uppsala, where a brilliant man named Leif Wiede had developed the immunologic pregnancy test, the heme agglutination inhibition pregnancy test. And I learned how to do that. Maybe you recall that before the immunoassays were developed, all pregnancy tests were done in animal tissue. They were used frogs, toads, rabbits, and rats to inject urine and see if ovulation occurred or hyperemia of the uterus and gonads. And that was very inaccurate. There's a high rate of false positives and false negatives. So Dr. Wiede had developed this heme agglutination inhibition test, which was the first immunoassay could be done. There was before the days of radioimmunoassays, so this was heme agglutination inhibition. Red cells, sheep red cells were coated with HCG, and then antibodies to HCG were added along with the patient's urine to see if the test was positive or negative. And you had an answer in a couple of hours. So I was a resident then. And I came back and set up this heme agglutination inhibition assay at the laboratory at Harbor General. And Professor Mastriani gave me the funds to set up the laboratories. And he was the chief of OB/GYN at Harbor in those days before he went to Pennsylvania. And I was able to measure HCG for the first time by immunoassays in the United States. It was a fascinating experience to do this, and I didn't patent it. I don't know if Dr. Wiede patented it, but we used this to measure HCG, and we're able to tell that in patients with threatened abortions, they had low levels of HCG. If they were going to have an ongoing pregnancy, HCG levels were higher, and did several publications. I was the first one to do immunologic assay of HCG in serum, and did that. And also was because HCG and LH were similar biologically, I used this assay to develop the LH ovulation prediction test with the same assay, except using urine from non-pregnant women at different days to see if they had a rise in LH. And they did. So this was a measurement of LH in urine, which was the first immunoassay that you could tell when a woman was going to ovulate. I also didn't patent this, but somebody did, and the rest is history, that we have immunoassays now for HCG and also for LH. So that was quite an exciting experience to do that as a resident. And I must mention that another icon for me was Professor John Vincent Kelly, who was on the UCLA faculty, and he had brought back a vacuum extractor from Sweden. And when I was a second-year resident, I did a study comparing the compression of the fetal scalp with the vacuum compared to forceps. I found out the vacuum was much less. Obstetrician gynecologists were so much afraid of the vacuum because it caused disfigurement of the baby. But that was my first study that I did as a second-year resident and presented it at the annual clinical meeting of the American College of Obstetrician Gynecologists. So I'm forever grateful to Dr. Kelly and Dr. Mastriani for providing me with the techniques to be able to do research as a resident. And it was when I was done doing that, Dr. Mastriani offered me a position as a faculty member at Harbor, UCLA.
He was obviously well known for being involved in reproductive endocrinology. Of course, at that time we didn't have subspecialties. Everybody just did what they wanted to do. Do you think that he identified you, or that just your two interests led you to get together with him so that he saw the potential for you?
With Dr. Mastriani?
Yeah.
Well, he was the one who sent me to Sweden, and he was the one who offered me the position. And unfortunately, he's not with us any longer, so you can't ask him why he chose me to be a junior faculty person. But he did, and I'm forever grateful to him. One other thing, Ralph, that Dr. Mastriani did was he told me not to follow in his footsteps in doing the same research he was doing, which was in the field of infertility. This is way before IVF, and we were doing microsurgery on the oviducts for patients with tubal disease, and using the new drug clomiphene citrate to induce ovulation. And I was one of the original investigators for clomiphene. And so that was a major breakthrough in our specialty, the development of clomiphene citrate to use to induce ovulation in anovulatory infertile women. But Dr. Mastriani, in his wisdom, told me, he says, you ought to go into the field of contraception. So there's nobody in academic obstetrics and gynecology who's doing that. And it was great advice. So I was able to work with several pharmaceutical companies studying Depo-Provera, which was a new steroid method of contraception, using lower doses of steroids and contraceptive pills, which I did. And also was able to work with the people from Upjohn to help develop the contraceptive vaginal ring. And did the first studies with the vaginal ring showing that the steroids in it were absorbed and could be used as a contraceptive. This was way back in the 1970s.
As I recall, during that time, actually people were scoffing because they said you couldn't absorb through the vagina.
That's true, despite good evidence that all sorts of materials unidirectionally go from the vagina into the circulation, but not from the circulation into the vagina. So that was pretty exciting. And in 1970, several things happened in 1970. One is Sheldon Siegel, another giant in our field, established what was called the International Committee for Contraception Research at the organization called the Population Council. And Dr. Siegel brought together a distinguished group of scientists, and I was fortunate to be the only American included. There was Dr. Fondas from Chile, and Dr. Lukainen from Finland, and Dr. Let's see, I got China, Finland. There was two other gentlemen, Dr. Coutinho from Brazil, and Dr. Johansson from Sweden. And we'd meet 3 or 4 times a year in New York, and this small group of scientists working with the laboratory of the Population Council there developed the copper IUD with the help of Dr. Tatum, who was Howard Tatum, another leader in our field, who was the person who realized that adding copper to this small plastic device, a T-shaped device, would prevent pregnancy and act as an effective pregnancy. The small plastic T without copper had a very high pregnancy rate because it didn't stimulate enough inflammatory reaction to kill all the sperm. But adding copper to it did, and Dr. Tatum developed a T, and it's marketed as the copper T200 from the Population Council. Also working with Dr. Lukainen from Finland, developed the levonorgestrel releasing intrauterine system, which is now sold as Mirena in the United States. So the council developed these two types of contraception, which are still in use today, and developed the NDA. And it was all this International Committee for Contraception Research. They just had their 100th anniversary meeting a couple of weeks ago. And this organization also developed the first subdermal implantable contraceptive, which is called Norplant, which is not used anymore because it was 6 capsules, but then was the forerunner of Jadel, which is 2 cell-elastic rods, and then the Implanon device, which uses a different steroid other than levonorgestrel. So it was pretty exciting to help develop these major methods of contraception, which are now called the long-acting methods of contraception, long-acting reversible contraception, or LARC, L-A-R-C. This method of contraception was developed by the Population Council, International Committee for Contraception Research, and I was pleased to be involved in the development of these devices.
When did you leave Harbor?
That's an interesting story, Ralph. When I was at Harbor, Dr. Mastriani went back to become the chair at the University of Pennsylvania, chair of OBGYN. And then they had a search committee, and they selected Ted Quilligan to be the successor to Dr. Mastriani. He was at Case Western Reserve, and he came out, and I was the only other full-time faculty member at that time. And then Dr. Quilligan recruited Dr. Dwayne Townsend and Val Davijan to the faculty, which was quite a headstrong group of individuals. But then Dr. Quilligan was offered the chair position at Yale University. And he accepted it and went back to Yale. And then they had another search committee looking at candidates to be the chief at Harbor. They had several people out, but no one accepted it. So I guess as a last resort, even though I was just a few years out of my residency, Dr. Daniel Morton, the chair at UCLA, selected me to be the head of the Department of Obstetrics Gynecology at Harbor, UCLA. And I did that, and then in 1969, Ted Quilligan was offered and accepted the chairmanship at the University of Southern California School of Medicine. And he accepted that position. And it was a unique experience because part of the county system, there were 2 hospitals there, the big general hospital and another smaller hospital with only 450 beds. Was called Unit 2. And it belonged to the California College of Medicine, which was an osteopathic medical school. And they moved out to Irvine to become University of California, Irvine, California College of Medicine, leaving this empty hospital with, I think it was 26 funded positions, and that's what enticed Dr. Quilligan to leave Yale to come out to USC. He also liked the weather, and when his time there, his family liked living in California. So Dr. Quilligan recruited giants to the area. I was head of reproductive biology, we called it that time. There were no specialty boards, but Roger Freeman was there doing maternal fetal medicine, and along with Dick Paul. And there was also oncology with Phil Desaya and Paul Morrow. And I guess the other subspecialty was reproductive endocrinology, which I was in charge of, and I had Uwe Gobelsman, who came from Michigan to help set up a great hormone laboratory. So this was started in 1969 and kept going to 1978 when Dr. Quilligan accepted an offer at University of California, Irvine And the search committee at USC selected me to be the chair. And I accepted this offer in 1978 and was chair until 2005. Trained over 350 residents.
You were also weren't you one of the founding people of the journal Contraception?
Oh, I forgot to mention that. That's the other event that occurred in 1970, that a biochemist named Ralph Dorfman, who had worked at the Worcester Institute for Biology where the birth control pill was developed, became an employee of the Syntex Corporation, which had synthesized the synthetic progestins, which are used in birth control pills. And Dr. Dorfman had the idea that there should be a journal devoted to contraception. And he owned a small publishing company called Geronix, named after his two sons, Gerald and Ronald. And he asked me to be the editor of this journal, the new editor in the new journal, which I did in 1970. It was a monthly journal. In the beginning, I had difficulty accepting articles because there weren't that many of any quality submitted to this brand new unknown journal. The articles were published in offset print, so that they were published rapidly because they didn't have to be typeset, and that appealed to some people. And the journal improved in the quality of the submissions. And as the field of contraception grew, more and more articles were submitted to the journals. I've remained the head editor since the journal was established in 1970. And so I think that's 42 years of being the editor of this journal. I'm stepping down as editor at the end of this year. And there's a selection committee to choose my successor, which has not been done yet. So I'm going to step down as editor of this journal. It's been a great experience being editor of a journal devoted to contraception and seeing how the number and the quality of the manuscripts has increased over this past several decades.
And the methods have improved.
Oh, absolutely. Absolutely. They're first oral contraceptive contained 9.85 milligrams of progestin, 150 micrograms of mestranol, ethylene estradiol, 3-methyl ether. And although blood clots were uncommon, they were markedly increased with these high doses of estrogen, as well as heart attacks and stroke. And so the dose of estrogen and progestin was markedly decreased and led to safer steroid contraceptive methods.
And as I recall, one of the first intrauterine devices was also Alza-T, and that the first experiment of putting progestins in a micromirror type of system.
That's right. And that was developed by Anthony Scomegna in Chicago, who worked with Alza, which was the Alza Corporation. Alejandro Zaffaroni, it was named for his first 4 initials, was one of the original founders of the Syntex Corporation. And he had the brilliance to develop a progesterone-releasing T-shaped IUD. Progesterone diffuses out through plastic much more rapidly than levonorgestrel, so the progesterone-releasing device had to be replaced each year, but it was a forerunner of the levonorgestrel-releasing device, which, as I told you, was developed by the Population Council and Dr. Lukainen.
You probably don't remember, but you called me and asked me if I'd be willing to have patients on the Alza-T as a part of a research study. That goes back a long time ago.
Wow. And you accepted?
And I accepted, because of you.
Well, thank you.
Okay,
Thank you.
sorry.
Yeah, I was very pleased that the Food and Drug Administration approved the marketing of the Progesticert, or the Alza-T.
What do you see as the future of contraception in this country? Do you think we've reached a stable or static, or do you think there is going to be further development?
Well, I'm sure there's going to be further development. It's just that there's not as many pharmaceutical companies willing to spend the money to develop new methods. And the process is so much more complex these days to have an NDA approved than it was back when the first pill was developed. Back in 1957, when Celso Ramon Garcia and Gregory Pincus and John Rock were developing the birth control pill, they only did studies for about 2 years before the FDA approved it. On a relatively very small number of women studied for 1 year. Now much more safety issues are required and a lot more money to develop an NDA for contraception. And you asked me what I think is the future of new contraceptives. I think there's going to be tweaking on the different steroids in the oral contraceptive pill. I think there's going to be newer developed, less expensive, probably longer lasting intrauterine devices. But I don't see a magic bullet like a vaccine or a male contraceptive being developed. There's been a lot of money spent on research of these agents, but I just don't see anything major being developed. I think we'll have steroid contraceptives that'll be given in gels and injections and different routes of administration. We already have the vaginal ring, and there is a contraceptive patch. I think that new methods of contraception. I think estradiol instead of ethinyl estradiol hopefully will be less thrombophilic and lead to less side effects. So I think there's a way to go, but I think it's going to be much slower, and I don't see any major breakthrough, at least in my opinion, of a new different method of contraception.
Let me just take you back to one other thing for just a short time that we have left. You developed quite a program at USC. You listed some of the fellows. When you look at the faculty that you brought together and brought there, they are all been leaders in our specialty. How did you accumulate such an outstanding group of fellows at your at USC when you were there?
I think it was Ted Quillian. Maybe I helped, but I think he had such an engaging personality, and he was such a great hands-off chair, which I've tried to be. I've tried to delegate things and I think that's one of the big advances is that delegation to other faculty, to let them do what they think without interfering or stifling their advances. I think that, and we all got along well together. There were women faculty too. That's one thing I didn't mention is when I became the chair in 1978, I think we had 16 residents and 15 were men. And gradually that's all changed and reversed. But back in the 70s, nearly all the residents in OBGYN were men, and that changed, a dramatic change after that time. We were all part of it. That and the subspecialty development gave autonomy to these individuals in their own subspecialty. And we hoped we were able to keep them happy and give them sufficient time. And back in those days, the major method of advancement in academic medicine was doing research. And there was sufficient time to do research, and people could do publications. And it was just an exciting time, especially with the individuals that I've mentioned. I'm sure I've left other people off that list. Val Davishon really helped me do a lot of work in endocrinology. One thing I didn't mention was that I was able to recruit Ian Thornycroft, who was a PhD before he became a doctor and then an obstetrician gynecologist and chair at the University of South Alabama. I recruited him out of Worcester Institute to set up an assay for estradiol. So in our little laboratory at USC, that was another thing that the dean gave us. Roger Eggerberg was the dean at that time, and he recruited Ted Quillian. He gave us a great endocrine research lab. And with the help of Ian Thornycroft, we were able to characterize by radioimmunoassay the patterns of FSH, LH, estradiol, and progesterone in the menstrual cycle. First ones to do so. So that was a quite an achievement.
Dan, you've been a leader in our specialty for a long, long time. And to me personally, you've been a marvelous help in all the things that I have done. And I thank you very much for coming here today and sharing your story with you. It is a remarkable what you have been able to accomplish. Thank you very much.
And thank you for inviting me, Ralph, and thank you for being a friend for all these many years.